Of our discussion today is pelvic inflammatory disease and sexual and reproductive health. Basically, in this topic, we will be covering different sort of infections like gonorrhea, chlamydia, Trichomanas Vaginalis, molluscum contagiosum, Candidiasis, human papillomavirus, and bacterial vaginosis. This topic is in several obs and gynae books like Dewhurst, EMEM, Dentagers, but basically, I have made this presentation from the BASHH guideline, from the latest BASHH guideline about the different sort of infections, because those are all latest recommendations, and the doses of antibiotics and proper regimens, the test of cures, all of these things are very important to consider, and those cannot be found in the books like EBM Dewhurst, because those books are not updated as much as guidelines are updated. Okay, so a test for the diagnosis of PID, basically we do ESR, CRP, laparoscopy, endometrial biopsy, ultrasound scan. These are the tests which basically helps in the diagnosis of PID. Means these are not the definitive test for the diagnosis of PID. We not only have to do different sort of tests, but also we have to take proper history from the patient, and based upon the history, examination, type of discharge, fever, the clinical presentation, the vital sign, and then these investigation based upon all these things, we can make the diagnosis of PID. So, what is the outpatient treatment for the patient who presents with PID? This is from the guideline that oral ofloxacin 400 milligram twice daily plus oral metronidazole 400 milligram twice daily for 14 days. So 2 weeks regimen. Both are 400 milligram twice daily, and that is recommended outpatient regimen for patient with PID. Then we can also give another regimen like intramuscular ceftriaxone 500 milligram single dose followed by oral doxycycline 100 milligram plus metronidazole 400 milligram twice daily for 14 days. Ofloxacin should be avoided in women at a high risk of gonococcal PID due to increased quinolone resistance in UK. Outpatient treatment of PID is recommended in different situations. IV therapy is recommended in patient with pyrexia when the temperature is more than 38 degrees centigrade, when we have signs of tubo-ovarian abscess or pelvic peritonitis, or when patient is intolerant to oral therapy, or when the patient is pregnant. Now, important point is that continue IV therapy until 24 hours after clinical improvement and then switch to oral. Okay, now inpatient regimens. Inpatient regimens are also very important. Inpatient antibiotic treatment should be based on intravenous therapy, which should be continued until 24 hours after clinical improvements and followed by oral therapy. Recommended regimens are ceftriaxone 2 gram by intravenous infusion daily plus intravenous doxycycline 100 milligram twice daily followed by oral doxycycline 100 milligram twice daily plus oral metronidazole 400 milligram twice daily for a total of 14 days.
Okay.
Oral doxycycline may be used if tolerated while on intravenous ceftriaxone. Intravenous clindamycin 900 milligram 3 times daily plus intravenous gentamicin followed by either oral clindamycin 450 milligram 4 times daily to complete 14 days, or oral doxycycline 100 milligram twice daily plus oral metronidazole 400 milligram twice daily to complete 14 days. Gentamicin should be given as a 2 milligram per kg loading dose followed by 1.5 milligram per kg 3 times daily, or a single daily dose of 7 milligram per kg may be substituted. Intravenous ofloxacin 400 milligram twice daily plus intravenous metronidazole 500 milligram 3 times daily for 14 days. Now, gonorrhea. How would we treat gonorrhea? And what is gonorrhea? Causative agent of gonorrhea. Gonorrhea is basically gram-negative intracellular diplococcus. You can see from the slide. Incubation period is 1 to 14 days. It's very important to remember incubation period. And I have made a separate slide in the end of this video in which I have compiled all the incubation periods, and you can take screenshot of that and memorize it. Now, presenting symptoms of patient with gonorrhea: mucopurulent vaginal discharge, urethral discharge, and dysuria. Now, complications of gonorrhea: it causes epididymoorchitis in less than 1% of the cases, the skin lesion, arthralgia, arthritis, tenosynovitis, and disseminated gonococcal infection in less than 1% of cases, and PID in 14% of the cases. These are very important points. Okay, epididymoorchitis in less than 1% of cases, PID in 14% of cases. These percentages are important for exam point of view, both for MRCG and FCPS part 2, because these percentages are asked, and these percentages are basically from BASHH guidelines, so these are authentic. Okay, now coming to the diagnostic test. Diagnostic test is that of NAT. Okay, nucleic acid amplification test. In more than this is more than 95% sensitive for gonorrhea. You have to remember this point. And when it is asked that which type of swab is more sensitive, then we would say that vulvovaginal swab is more sensitive than endocervical swab or a first catch urine in the woman. This is very important because certain exam question also ask about the type of swab. Okay, and the scenario is usually given that patient comes with dysuria, urethral discharge, arthritis, mucopurulent vaginal discharge, arthritis, etc. So, what test would we do? So, in the option, usually it is written that do the vulvovaginal swab or low vaginal swab, or endocervical swab in another option, and different other options are given. So in that case, you have to choose the low vaginal swab or vulvovaginal swab that is more sensitive than endocervical swab. Okay, so vulvovaginal swab has sensitivity of 96 to 98%. And this is also very important that it takes about 2 weeks for NAT test to give result. 2 weeks is basically the window period. Okay, so window period is the time when the NAT test, the time which NAT test takes to get the result. And all patients found positive with the NAT should be followed by culture as well in gonorrhea, but not in chlamydia. Now, treatment of uncomplicated anogenital and pharyngeal infections like gonorrhea, antimicrobial susceptibility is not known. When we are not known, we don't know about antimicrobial susceptibility, then we give ceftriaxone 1 gram IM as single dose, and antimicrobial susceptibility, when it is known, then we give ciprofloxacin 500 milligram orally or as a single dose. Now, this is also a new update that dual therapy with azithromycin 1 gram is no longer recommended. Okay, means when we have something else along with azithromycin, that is not recommended. Alternated treatment for gonorrhea: cefixime 400 milligram orally as a single dose plus azithromycin 2 gram orally, and only advisable if intramuscular injection is contraindicated or refused by the patient. Resistance to cefixime is currently low in UK. Gentamicin 240 milligram intramuscularly as single dose plus azithromycin 2 gram orally. Now, gonorrhea in pregnancy and breastfeeding. Pregnant and breastfeeding individual should not be treated with quinolone or tetracycline antimicrobial. Pregnancy does not diminish treatment efficacy. Okay, so in pregnancy, we will follow this regimen: ceftriaxone 1 gram IM as a single dose, and spectinomycin 2 gram IM as single dose. Now, spectinomycin is in FDA pregnancy category B, and therefore should not be expected to be harmful and can be used if no suitable alternatives are there. It is not known if it is excreted in breast milk and should be used with caution in those who are breastfeeding. Azithromycin 2 gram as a single oral dose. Now, management of complicated gonococcal infection, gonococcal PID, ceftriaxone 1 gram as a single dose in addition to the regimen chosen to treat PID. Disseminated gonococcal infection, ceftriaxone 1 gram IM or IV every 24 hours, or cefotaxime 1 gram IV 8 hours, or ciprofloxacin 500 milligram IV every 12 hours if the infection is known to be susceptible, or spectinomycin 2 gram IM every 8 hours. Now, how long we will continue gonorrhea therapy? That is very important. Therapy should continue for 7 days, but maybe switch 24 to 48 hours after symptoms improve to one of the following oral regimens guided by sensitivity. Cefixime 400 milligram twice daily and ciprofloxacin 500 milligram twice daily, or ofloxacin 400 milligram twice daily. Now, follow-up and test of the cure for gonorrhea. At least one follow-up visit is recommended to confirm compliance with the therapy, resolution of symptoms, and partner notification. A test of cure is now recommended because the concern around antibiotic resistance. Okay, so it's very important when we will do the culture for asymptomatic patient. Culture is done after 72 hours, and when we have symptomatic patient, test of the cure should be done by the NAT, and 1 week for RNA NAT and 2 weeks for DNA NAT. Okay, after the treatment is completed. Now, infection identified at this point may be due to reinfection. All cases of gonorrhea should be seen by trained person, ideally cum health advisor, for partner notification and contact tracing. Now, we are finished with gonorrhea, so let's do the topic of chlamydia. What is causative agent of chlamydia? Obligate intracellular bacterium Chlamydia Trachomatis. Incubation period is 7 to 21 days. In the end of this video, I have compiled a list of incubation periods. D to K causes urogenital infection. L1 and L3 causes LGV. Okay. Now, risk factor for acquisition of chlamydia infection include young age, less than 25 years, a new partner, sexual partner within the past year, multiple sexual partner, and condomless sex. Okay. Now, complications of chlamydia includes PID. And this percentage is very important. 16% of untreated patients develop clinical PID. Perihepatitis feeds Hugh Curtis syndrome. Tubal infertility, 1 to 20% of cases. Ectopic pregnancy, sexually acquired reactive arthritis or SARA in less than 1% of the cases. Now, diagnostic tests for chlamydia include NAD. Vulvovaginal swab is more sensitive than endocervical swab or a first catch urine in a woman. Okay, vulvovaginal swab sensitivity is 96 to 98%. It takes about 2 weeks for NAT test to give results. 2 weeks is basically window period, but the thing which is different here from gonorrhea is that we don't need to do culture in chlamydia, but in gonorrhea we did culture as well. Now, management of Chlamydia Trachomatis in uncomplicated cases, recommended regimen is doxycycline 100 mg BD for 7 days first line, azithromycin 1 gram orally as a single dose, followed by 500 milligram once daily for 2 days. Okay, so initially we give 1 gram dose, then once daily 500 milligram for 2 days. Okay, alternative regimen include ofloxacin 200 milligram twice daily or 400 milligram once daily for 7 days, contraindicated in pregnancy. Erythromycin 500 milligram twice daily for 10 to 14 days. Now coming to the treatment of chlamydia in pregnancy and breastfeeding, azithromycin 1 gram orally as a single dose, followed by 500 milligram daily for 2 days we can give in pregnancy. Erythromycin 500 milligram 4 times daily for 7 days and twice daily for 14 days. Amoxicillin 500 milligram TDS for 7 days. Now, test of cure for chlamydia. A test of the cure is not routinely recommended but should be performed in pregnancy or if non-compliance or re-exposure is suspected. Done after 5 weeks after treatment, but it should be deferred to 6 weeks if azithromycin has been given after treatment is completed. Now, neonatal chlamydia. In neonates, it causes the ophthalmic neonatorium and pneumonia, and conjunctivitis develops 5 to 12 days after birth. Treatment: oral erythromycin 50 milligram per kg per day in 4 divided doses for 14 days. Now coming to Trichomonas vaginalis. Causative agent for Trichomonas vaginalis is causative organism is Trichomonas vaginalis. Okay, then incubation period is 5 to 28 days. Up to 50% of infected women may be asymptomatic. It may be acquired perinatally and occurs in 5% of the babies born to the affected mother, and this infection requires treatment of an asymptomatic partner as well. Now, diagnostics test for Chlamydia Trichomanas Vaginalis, the most sensitive test for reduction of Trichomanas Vaginalis is NAT test, and the treatment of Trichomonas vaginalis, the usual regimen. The recommended regimen for treating Trichomonas vaginalis infection include metronidazole 2 gram orally in single dose, and regimen in pregnancy, avoid pregnancy and breastfeeding or metronid. Okay, either we have to avoid that dose in pregnancy and breastfeeding, or we have to give metronidazole 400 to 500 milligram twice daily for 5 to 7 days. Alternative dose include tinidazole 2 gram orally single dose. Okay. Now coming to molluscum contagiosum, causative agent, it is caused by pox virus, and incubation period is 3 to 12 weeks, and management include podophylotoxin 0.5%, imiquimod 5%, liquid nitrogen therapy. Alternative treatment includes the curettage. Candidiasis. In candidiasis, the clinical presentation is that patient presents with curdy, white, cottage cheese-like discharge. In 10 to 20% patients are asymptomatic. Vaginal candidiasis is associated with estrogen. Satellite lesion may be present on inner thigh and abdomen. And treatment of candidiasis, first of all, we have to discuss the treatment of acute vulvovaginal candidiasis. First or second isolated presentation of vulvovaginal candidiasis is acute vulvovaginal candidiasis, and patient presents with a sign and symptom of acute vulvovaginitis, and candida species can be detected by microscopy and culture. Now, acute vulvovaginal candidiasis recommended regimen include fluconazole capsule 150 milligram single dose orally. Recommended topical regimen. If oral therapy is contraindicated, we can prescribe clotrimazole pasri 500 milligram as a single dose intravaginally. Now, severe vulvovaginal candidiasis recommended regimen is fluconazole 150 milligram on day 1 to 4. Alternative regimen include clotrimazole 500 milligram pasri intravaginally on day 1 to 4. Miconazole vaginal capsule 1200 milligram on day 1 to 4. Now, recurrent vulvovaginal candidiasis, at least 4 episodes per 12 months, with 2 episodes confirmed by microscopy or culture, and when symptomatic, at least one must be culture. And recurrent vulvovaginal candidiasis recommended regimen induction. At the time of induction of the dose, we gave fluconazole 150 milligram orally every 72 hours for 3 doses, and maintenance dose include fluconazole 150 milligram orally once a week for 6 months, and alternative regimens include induction. Topical imidazole therapy can be increased to 7 to 14 days according to symptomatic response. Maintenance for 6 months, clotrimazole pasri 500 milligram intravaginally once a week, and itraconazole 50 to 100 milligram orally daily. Now, pregnancy and breastfeeding recommended regimen include acute vulvovaginal candidiasis in pregnancy, clotrimazole pasri 500 milligram intravaginally at night for up to 7 consecutive nights. And now coming to human papilloma virus, causative agent of human papilloma virus, incubation period 3 weeks to 8 months, and it's a DNA virus. Presentation of human papilloma virus, it can be asymptomatic or small. Multiple lumps may be keratinized or non-keratinized, and treatment include ablative treatment, cryo or cautery, or electrocautery or cryocautery. Choose ablative method, especially in case of keratinized wart or in pregnancy. Trichloroacetic acid, podophylotoxin, imiquimod, and 5-fluorouracil. Bacterial vaginosis. Bacterial vaginosis treatment. Bacterial vaginosis is characterized by an overgrowth of predominantly aerobic organism, Gardnerella vaginalis, Prevortilla species, Mycoplasma homonymous, Mobiluncus species in the vagina. This leads to replacement of lactobacilli and increase in pH from a normal of 4.7 to 4.5 to 7. Diagnostics test for bacterial vaginosis. AMSEL criteria for diagnosis bacterial vaginosis: at least 3 out of these 4 should be present for diagnosis to be confirmed. Thin, white, homogeneous discharge, clue cell on microscopy, pH of vaginal fluid of more than 4.5, release of the fishy odor on adding alkali 10% KOH, and this test is really performed these days. Now, management of bacterial vaginosis using the oral route of administration. Recommended regimen for treating bacterial vaginosis includes the metronidazole 400 to 500 milligram twice daily for 5 to 7 days, or metronidazole 2 gram as a single dose. An alternative approach is to use vaginal route with intravaginal metronidazole gel 0.75% once daily for 5 days, or intravaginal clindamycin cream 2%, 300 milligram BD for 7 days. All these treatments have been shown to achieve cure rate of 70 to 80% after 4 weeks in a controlled trial using placebo or comparing with the oral metronidazole. In alcoholics, metronidazole is avoided because of disulfiram-like actions. Okay, now incubation periods of different pathogens include, first of all, chlamydia incubation period is 7 to 21 days, gonorrhea 1 to 14 days, trichomonas vaginalis 5 to 28 days, pox virus 3 to 12 weeks, HPV 3 weeks to 8 months, syphilis 9 to 90 days, herpes 2 to 12 days, LGV 3 to 30 days, chancroid 4 to 7 days, Gonorrhea median 50 days, means 1 day to 1 year. Okay, thank you so much for your patience. Allah Hafiz.